Hello, hi guys. So apparently there was some technical issue and they kind of closed the session a bit early, and that was the reason why we had to create another link, and that's why there was a bit of a delay for that. Okay, so I don't know whether you guys will be seeing this or not, but yeah, let's kind of go ahead and kind of complete whatever I wish to kind of convey to you guys. Okay, so let's wait for a couple of minutes so that the students can join in, whoever wishes to join, and then we can kind of just proceed and complete whatever the things we have to. Okay, right? Okay, so right, just give me a minute. Okay, so we do have few students over here. Okay, just 1 minute. Okay, so finally, yeah, let's start. Let's start by talking about these things, guys. Yeah, okay, so let's start. So yeah, can you please tell me what is the answer over here? So there's a patient after the road traffic accident. What you need to understand is that there was a road traffic accident, was brought to the emergency, and her pulse rate was 50 beats per minute, and the blood pressure was 80 by whatever 60 mm Fiji. On evaluation, the ECG was normal. E first was negative for the chest. Like E first and the chest X-ray were kind of normal. This the patient would be classified as which type of shock? Okay, so are you guys really okay with this? Like Priyadarshini and Saket are basically saying the answer is A. Do you guys agree? Do you guys agree that the answer to this particular question is A? You really agree to this? No, the answer is not A, guys. So please try to understand. This is one of the very, very basics which they are kind of testing you over here. So what you need to understand, the answer to this particular question is neurogenic shock. What is the answer? Answer is the neurogenic shock. Okay, so what is the answer over here? Answer is neurogenic shock. So please try to understand. There is a basic funda which you need to understand over here. What is the heart rate of this particular patient? Heart rate of this particular patient is 50 beats per minute. If at all it was a hypovolumic shock, what would have happened to the heart rate? The heart rate would have gone up. Are you understanding my point? So in the neurogenic shock, everything basically goes down. The heart rate, the blood pressure, pulmonary capillary wedge pressure, the GVP, everything basically goes down in the neurogenic shock. Okay, so let's kind of just quickly revise a couple of shocks. The most important shock which we need to understand is the hypovolumic shock. Hypovolumic or the hemorrhagic shock. Hemorrhagic shock. Okay, so the most common type what we have is a hypovolumic or the hemorrhagic shock. Now in this, what you need to understand is that there's a blood which is getting lost and everything, and because of this, what's going to happen, there is going to be the let's talk about the parameters. Okay, let's talk about the parameters. What is going to happen to the cardiac output? The cardiac output is going to kind of go down. What is going to happen to the heart rate? The heart rate is basically going to go up. What about the JVP? The JVP of this particular patient is basically going to be a bit less. Okay, so it is going to be lower than normal because the blood is basically getting completely lost. Okay, so that is what you need to understand over here. What about the pulmonary capillary wedge pressure and all those things? They are going to basically go down. Okay, what about the total peripheral resistance? Total peripheral resistance is going to go up, and because of this, what we are going to have is we are going to have a cold and clammy extremities. So whenever there is a state of a shock, what happens is that the sympathetic overactivity happens, and because of the sympathetic overactivity, the heart rate basically goes up. So and the total peripheral resistance basically goes up. In the patients with the neurogenic shock, what is happening? That is the sympathetic outflow is basically cut off, and because of that, what is going to happen? That is the heart rate is going to go down. Then like the total peripheral resistance is basically going to go down, and that is why in the neurogenic shock, what you basically get is a warm extremities. Okay, what we get is a warm extremities. Okay, so Saket, I hope you have understood. Got confused. Okay, that's fine. I hope you have understood it right now. Okay, right. So yeah, that's what you need to understand. So all you need to understand is in neurogenic shock, all the parameters are reduced. All the parameters are reduced. Okay, now another thing which they keep on asking you about this is about the hemorrhagic shock. Okay, what they keep on asking you about the hemorrhagic shock is that what is the classification of the hemorrhagic shock? Okay, what is the classification of the hemorrhagic shock? Hemorrhagic shock. So what is the classification of the hemorrhagic shock? We have the class 1, we have class 2, we have class 3, we have class 4. Okay, so what about the class 1, guys? What about the class 1? In the class 1 hemorrhagic shock, what is the amount of the blood loss which is kind of there? Okay, what is the amount of the blood loss which is there in the class 1 hemorrhagic shock? It is less than 750 ml. Okay, so less than 750 ml is the blood loss of the hemorrhagic shock, class 1 hemorrhagic shock, which is basically less than 15% of the total blood volume. What about the class 2 hemorrhagic shock? Here the blood loss is basically between 750 ml to 1.5 liters. Okay, 750 ml to 1.5 liters, which is basically around 15 to 30%. That is the amount of the blood loss in the class 2 hemorrhagic shock. What about the class 3 hemorrhagic shock? In the class 3 hemorrhagic shock, the blood loss is basically between 1.5 liters to 2 liters, which is basically between 30% to 40%. Okay, 30% to 40% is the blood loss in the class 3 hemorrhagic shock. And what about the class 4 hemorrhagic shock? In the class 4 hemorrhagic shock, the blood loss is more than 2 liters or more than 40% of the total. Okay, so this is again something which is very important, very basic, but very important. This is something which you need to understand in the classification of the hemorrhagic shock. Another important thing is that in the class 1 hemorrhagic shock, what you need to understand is all the parameters are normal. Okay, over here all the parameters are normal. In the class 2 hemorrhagic shock, what you need to understand is that all the parameters are slightly deranged. And what parameters I'm talking about? I'm talking about heart rate, I'm talking about whatever respiratory rate, I'm talking about the urine output, I'm talking about the systolic blood pressure. Okay, so over here what you need to understand, all the parameters are slightly deranged. In other words, heart rate is slightly increased, respiratory rate is slightly increased, urine output is kind of slightly reduced, but the systolic blood pressure is kind of normal. Okay, so systolic blood pressure is normal over here. So in the class 2 hemorrhagic shock, all the parameters are slightly deranged, but the systolic blood pressure is normal. So this is important because the clinical scenarios can be formed around this. So what clinical scenarios can be formed around this? So they can give you that there is a patient with whatever the after the trauma, the patient came to you, and all the parameters, they'll give you that the heart rate is basically whatever 105 per minute, and then they'll give you the respiratory rate is slightly kind of elevated, the urine output is let's say 26 ml per minute, and all those particular things they will give you. But they will give you that the systolic blood pressure of this particular patient is normal. So what is the diagnosis of this particular patient? It is a class 2 hemorrhagic shock. Class 3 and class 4, the parameters continue to get deteriorated, and ultimately the patients become anuric and everything. So this is not that important, but what is important is the class 1 and the class 2 hemorrhagic shock. They are very important. Okay, all the parameters are slightly deranged, but the systolic blood pressure is normal. This is what is the class 2 hemorrhagic shock. Do not forget this. This is important clinical scenario which they keep on asking you. Okay, now there is a patient who came to presented to the OPD complaining that the walking a certain distance, he feels there is a pain in the calf region, because of which he cannot walk any further and has to take rest. As per the Boyd's classification, which of the following is the grade of this particular kind of a patient? Okay, so this is important. This is what is called as a Boyd's classification for the peripheral vascular disease. Okay, so what is this particular Boyd's classification for the peripheral vascular disease? So okay, so whenever you have a patient with the peripheral vascular disease, PVD, okay, whenever you have a patient with the peripheral vascular disease, what you need to understand is what are the symptoms. What are the symptoms of these particular patients? The symptoms of these particular patients are intermittent claudication and Raynaud's phenomenon. Are you understanding my point? So the symptoms of these particular patients are the intermittent claudication and the Raynaud's phenomenon. These are the two important symptoms which you basically have in the peripheral vascular disease. I hope you are able to understand this particular point, guys. Okay, now in the intermittent claudication, what you have is a Boyd's classification. Now this is again very important. So let's look at the Boyd's classification. Okay, so what is this Boyd's classification, guys? So Boyd's classification is basically like we have a Boyd's type 1, type 2, type 3, and type 4. Okay, so what is type 1? In the type 1, what happens that the patient basically like develops pain when patient starts to walk, but pain disappears on continuous walking. Okay, so when the patient starts to walk, the patient develops pain, but when the patient continues to walk, the pain basically disappears. So this is what is your Boyd's type 1. Okay, what is Boyd's type 2? In the Boyd's type 2, what happens that the patient basically develops pain when patient starts to walk, but pain is not severe. So patient continues to walk with pain. So what is Boyd's type 1? That the patient starts to walk, patient develops pain. When the patient continues to walk, the pain basically disappears. What is Boyd's 2? The pain starts to walk, but there was pain and the pain was not very severe. So pain was bearable. So patient basically continued to walk with pain. That is what is the Boyd's type 2. What about the Boyd's type 3? Boyd's type 3 is that when the patient starts to walk, the patient develops pain and the pain was severe. And so patient have to take rest. Patient have to take rest. Okay, so patient have to take rest to relieve the pain. So what you need to understand that once the patient takes rest, the pain basically goes down. Are you understanding my point? So patient develops pain, the pain is severe, and patient has to kind of take rest to relieve the pain. That's what you need to understand over here. Okay, now what about the Boyd's type 4? Boyd type 4 is basically rest pain. Okay, so this is what is referred to as a rest pain. That is, the patient has pain even at rest. So this is important. Now, just 1 year back, the Boyd's classification was asked to you in your FMGE exam. So if you don't remember this, please do understand it. I'll just repeat it. It's very simple, nothing major about that. When the patient starts to walk, patient develops pain. When the patient continues to walk, the pain basically disappears. Boyd's type 1. Patient starts to walk, patient develops pain, and pain is not that severe. So patient continues to walk with pain. Boyd's type 2. Boyd's type 3. Patient starts to walk, patient gets pain, which is severe. Patient has to kind of take rest in order to relieve that particular pain. And 4 is basically rest pain. Okay, so this is what you need to understand about the Boyd's classification. Okay, so this is what you need to understand about the Boyd's classification. Okay, now when we talk about the investigation of choice, so what is an investigation of choice for the peripheral vascular disease? It is DSA, that is digital subtraction angiography. And what you basically get in this particular digital subtraction angiography, so what you get is a corkscrew collaterals. Okay, so what you basically get is a corkscrew collaterals. Okay, so this is what you need to understand. This is what is a digital subtraction angiography image, and what you're basically getting over here is a corkscrew collaterals. Okay, what you're basically getting over here is a corkscrew collaterals. Okay, I hope you're able to understand this point. No, investigation of choice is not ABPI, Saket. Okay, so like ABPI, ankle brachial pressure index, is not an investigation of choice. Ankle brachial pressure index is one of the investigations which you can do in these particular patients. That's fine. So what is this ankle brachial pressure index? So normally what you need to understand is that if, let's say, we take what you call as if you basically what you call as okay, so what you need to understand is that if we take the kind of a ratio of the blood pressures in the upper limb and the lower limb in you and me, what is going to happen? It is going to be more or less normal. So what is this ABPI? What is this ABPI? ABPI basically stands for ankle brachial pressure index. Okay, what does this stand for? It stands for ankle brachial pressure index. So in this, what you basically do is you take the blood pressure in the ankle and you divide it with the blood pressure in the brachial artery. Okay, in the ankle, where do you kind of measure this blood pressure? So you measure this blood pressure in the posterior tibial artery or the dorsalis pedis artery. Okay, so you measure the blood pressure in the posterior tibial artery or the dorsalis pedis artery, the blood pressure in the ankle. And what about in the the hand? It is basically in the brachial artery. So you basically take the ratios of these two, and normally it should be kind of more or less normal. So what is the normal value of this? The normal value of this is basically between 0.8 to 1.1. This is probably the ABPI which we are going to have right now. Only one value if you want to remember, just remember, if at all the ABPI is less than or equal to 0.3, what does this mean? This means that there is a critical limb ischemia, and this basically means that the patient is at a risk of undergoing a gangrene and necrosis. The patient is at a risk of undergoing gangrene and necrosis. Okay, so I hope you are able to understand this particular point. Okay, so critical limb ischemia is when the ABPI is less than or equal to 0.3. This is what is a critical limb ischemia, and here the patient is at a risk of undergoing a gangrene and the necrosis. Okay, I hope you are able to understand these particular points. Okay, right. Okay, now shock waves of the air blast will commonly affect which part of the body? Okay, so blast injuries. Okay, so let's talk about the blast injuries. So the shock waves of the air blast are going to occur most commonly which part of the kind of a body? They are three. Wherever there are the organs which are having air inside it. Okay, air inside it. So the most commonly and the most severely. Okay, so there are two things. Okay, so out of this obviously you'll have to mark lungs, but overall what you need to understand is the most commonly affected organ is basically your middle ear, and most severely affected organ is your lungs. Okay, and whatever the solid organs we have, for example, let's say the liver or let's say the spleen, okay, these are resistant. Okay, so they are resistant to the effect of this particular blast injury. Okay, so the liver and the spleen, which are the solid organs, these are resistant to the effect of the blast injuries. Okay, I hope you have understood this particular point. Important. Okay, so the shock waves of the air blast most commonly affect what? So they most commonly affect which part of the body? The answer is lungs. So wherever there's going to be the air, for example the middle ear, that is what is most commonly affected. Lungs are the most severely affected. So that is what you need to understand and remember over here. Okay, right. Now let's move on to the next question. So the next question which we have is this: there's a patient who has a progressive dysphagia involving both the solids and the okay, so what is this? Let's kind of see about this. Okay, so what's the question? The question is that there is a patient who is having a progressive dysphagia which is involving the both solids and liquids, blah blah blah, regurgitation, chest pain, heartburns, weight loss. Imaging has been shown to you. What is the image of this? One of the most simplest of the questions which can be asked to you. So what is this? This is what is the characteristic here: bird's beak or the what do you call it, the rat tail appearance. So bird's beak or the pencil tip appearance. Okay, so this is what is your bird's beak or the whatever the rat pencil tip appearance. And what is the diagnosis over here? It is an achalasia cardia. Okay, so what is this? What is the diagnosis? It's not the carcinomyopathical med student. It is a achalasia cardia. This is a characteristic kind of a thing which is being shown to you guys. Okay, so why are you getting confused it with the carcinomyopathic? It is such a characteristic tapering of the esophagus like this. Okay, are you confused with this haziness? No, it is the stomach. Okay, so this is where the esophagus is kind of ending. Okay, I hope you're able to understand. This is what is a achalasia cardia. Okay, so let's talk about the important points about the achalasia cardia. In the achalasia cardia, what is the problem? The problem is that there is an absence of the ganglion cells. Okay, what is there? There is an absence of the ganglion cells in the lower part of esophagus. Okay, so there's an absence of the ganglion cells in the lower part of esophagus. Either they can be kind of congenitally absent or they can be acquired. Yeah, so these are the things what you need to understand. Acquired is basically because of the Chagas disease or the trypanosomiasis. So they basically lead to the destruction of these particular ganglion cells. But the thing is that the ganglion cells are absent. Okay, that's what you need to understand. Because of this, what happens? The lower esophageal sphincter that fails to relax, and because of this, there's a patients who are having dysphagia. So whenever they talk to you about the dysphagia, what they'll give you that the dysphagia is more to the liquids. Okay, it is more to the liquids as compared to that of the solids. Okay, so as we know that it is a progressive dysplasia. What is it? It is a progressive dysphagia. So it is going to start with the liquids, but ultimately even the solids will have the dysphagia. Okay, so it is a progressive dysphagia starting with the liquids. Ultimately the solids will also get affected. Okay, now what about the like for the diagnosis? For the diagnosis, what you can do is you can perform what you call as a barium swallow, barium swallow. And in the barium swallow, what are you going to get? You're going to get this bird's beak appearance, bird's beak, or a pencil tip appearance. Okay, bird's beak or the pencil tip appearance is something which you're going to get in the patients on the barium swallow. Okay, on the barium swallow, this is what you're going to get. Okay, now okay, now what you need to understand over here is that if I ask you about the investigation of choice, okay, investigation of choice over here. So investigation of choice over here is the what you call as a what is it? It is basically manometry. Manometry. Okay, so what is the investigation of choice over here? The investigation of choice over here is a manometry. What you need to understand over here, manometry. This is what is a high resolution manometry. Okay, so what you need to understand about over here is, just 1 minute. Okay, so what you need to understand over here is that whenever you have this, okay, whenever you have this particular kind of a manometry, the high resolution manometry, what you need to understand over here is that you are asking me to kind of talk to you about the types of the achalasia, right? So based on this particular high resolution manometry, what do we have? We have the 3 types of the achalasia. So when we talk about the types, we have the 3 types of achalasia. We have type 1 and type 2 and type 3. Now what you need to understand is what is a common thing between all the 3. The common thing between all of these particular thing is that there is something which is called as IRP. Okay, so this IRP is always more than 15 millimeters of mercury. Okay, so this is basically going to be more than 15 millimeters of mercury in all the 3. Okay, so this basically tells you that the intermittent relaxation pressure, so the relaxation pressure is always high, that is the lower esophageal sphincter is always in the state of a contraction. So that is what you need to understand. Now in the type 1, what you need to understand is that there is no pressure which is generated in the body of the esophagus. Okay, now here there is a pressure which is generated, but there is no effective peristalsis. And the pressure which is generated is basically, which is referred to as by the DCI. So the DCI is basically less than 450. So DCI is basically less than 450 millimeters of mercury. But in the type 3, this is also called as a high pressure. Okay, so this is what is called as a high pressure. So here in the type 3, what is there? There is a pan-esophageal contraction. There is a pan-esophageal contraction. And over here, what you need to understand is that the DCI is more than 450 millimeters of mercury. Okay, so I hope you're able to understand this particular point. So yeah, that is what you need to understand over here. So did you understand this point? So it is not okay, so it is I'm really sorry for this. It is not exactly the millimeters of mercury, it is Hg per second per centimeter. So the like the unit is a bit different over here. So this is what is called as a Hg per what you call as second per centimeter. So this is what is the amount of the pressure which is generated per centimeter of the esophagus. So Hg per second in one particular second. Okay, so Hg per second per centimeter, that is not kind of important. What is important is in the type 3 the DCI is more than 450, and in the rest the DCI is basically less than 450. So in type 1 and type 2. And what is the common thing? The common thing is that the intermittent relaxation pressure, the IRP, is basically more than 15 millimeters of mercury in all the 3. Okay, I hope you have understood this particular point. Got it? Okay, right. So that is how you kind of distinguish between the type 2, type 3, and type 1, type 2, and type 3, whatever achalasia cardia. Okay, I hope you have understood this point. Okay, now what else you need to understand? So what about the management? Like how do you manage the patients of your achalasia cardia? So okay, you can try what you call as your medical management can be tried. You can also try the surgical management. So like when we talk about the management, so we have the medical management, then we have an endoscopic management. In the endoscopy, what you basically do is you basically go ahead with what you call as a Botox injection, okay, or dilatation. Okay, so you can go it with a Botox injection, or you can go it with a dilatation of the lower part of the esophagus. Yeah, that's what you can do. And what you can do is, for the surgical, what you need to understand is that you perform a Heller's cardiomyotomy. So here what you basically perform is a Heller's cardiomyotomy. Okay, so here what you basically perform is a Heller's cardiomyotomy. Okay, and finally there is a procedure by the name of POEM. What is this POEM? This is per oral endoscopic myectomy. Okay, so what is this POEM's procedure? This is per oral endoscopic myectomy. So these are the things which you basically have in the patients for the management of the achalasia cardia. Okay, so in the management of achalasia cardia, these are the things which you basically have. Okay, I hope you have understood this particular point. Okay, now, so this is what is an image of your POEMS procedure. What is this? This is what is a POEMS. This is per oral endoscopic myectomy. So once they had asked you in the FMGE exam that POEMS is used for what? So POEMS is basically used for per oral endoscopic myectomy. Okay, I hope you have understood this point. Okay, now refeeding syndrome, electrolyte abnormalities are not seen. So hypokalemia, hyperkalemia, hypocalcemia, hypophosphatemia. So what is this particular refeeding syndrome? So let's say if at all there is a patient who is in the state of a chronic starvation. Okay, so if at all let's say there is a patient who, so just remember in the refeeding syndrome what happens, there is a phase of anabolism which happens, and in the anabolism what happens, all the micronutrients are used. Okay, so all the micronutrients are used, and that is why we get hypokalemia, we get hypocalcemia, we get hypophosphatemia. And this is like the refeeding syndrome. We have to kind of take it a bit seriously, because this can lead to the cardiac abnormalities. And when it is going to happen, this particular refeeding syndrome usually happens when the patients are in the state of a chronic kind of starvation, and then you suddenly start these particular patients on the, you give the food to these particular patients, or you start these particular patients on the TPN, then there is a risk of this, what you call as a refeeding syndrome to happen. Okay, now this is an important MCQ. This was asked to you in your FMG. A 5-day-old baby was brought to the emergency with a bilious vomiting. So there is a patient who has been brought to with, or like the 5-day-old baby has been brought to you with a bilious vomiting and what you call as an abdominal distension. On abdominal X-ray, there are multiple air fluid levels are seen. No gas under the diaphragm is visible. Baby is otherwise stable. What should be the immediate treatment for this particular baby? Okay, so yeah, please tell me what should be the answer. So here, essentially, there is a 5-day-old baby who is basically in the state of intestinal obstruction. Okay, so what is the management of this particular patient? Okay, so what you will do is immediately do a colostomy and fix the obstruction, bowel resection, okay, and anastomosis. Okay, so what is the answer over here? What is the answer? What do you think? The answer over here is a temporary colostomy and fixed obstruction later. Okay, so what is the answer? The answer over here is C, guys. Okay, and this is a repeat question from your FMG, so please do remember this. What is the answer over here? This is a temporary colostomy with the fixing of the obstruction later on. Okay, why this is, it's not a triple bubble or anything like that. Okay, here what you need to understand is that whenever you are whenever the patient comes in the emergency, and these particular patients are having intestinal obstruction. So what you need to understand is, the first thing which you have to do is, okay, so here the problem with these particular patients are that they are dehydrated. They have what I call as electrolyte deficiencies. The electrolytes are very, very low in these particular patients. They are dehydrated to the core. All these particular things are there in these particular patients, right? So whenever they give you this particular type of a scenario, that there is a patient who has been brought to the emergency, patient is in the state of intestinal obstruction, the management part, you just do what is absolutely needed. So here there's a 5-day-old patient who is basically in the state of intestinal obstruction. Obviously a temporary colostomy will be needed. Okay, so temporary colostomy will be needed, and obviously you'll have to take care of the obstruction, but it's not mandatory for you to take care of the obstruction right away, because at this point of time the patient is not in a best of the hemodynamic state, right? So you can do a temporary colostomy and you can fix the obstruction later. Okay, so you can fix the obstruction later on, at the later kind on date you can kind of fix the obstruction. So this is not just for this. For example, even if they kind of give it that there is a patient, 65-year-old male patient, coming to you with a colorectal malignancies, and now the patient is basically in the state of intestinal obstruction, what you do is you do a diversion colostomy, and then you kind of once the patient is stabilized, then you basically manage whatever the colorectal malignancies the patients are having. Okay, I hope you're able to understand this point. Important. That's a concept which is important. Now, a patient coming to you with the patient presents with the peritonitis, and during the surgery, there's a diverticular perforation is seen with the fecal peritonitis. Okay, so patient had a peritonitis, and during the surgery, there was a diverticulum which had perforated, and the patient had a fecal peritonitis. Fecal peritonitis. What is this Hinch's kind of a stage? Okay, what is this Hinch's stage? So can you please help me? What is this particular Hinch's stage? Yes, it is 4. Okay, what is this? This is a Hinch's classification, Hinch's type 4. Okay, right. So let's talk about the diverticulitis. Okay, so let's talk about the diverticulosis and the diverticulitis. Okay, so what you need to understand is that if at all there is a patient who has had a chronic constipation. Okay, so there is a patient who had a chronic constipation. Okay, chronic constipation has happened in any particular patient. So what is going to happen? Because of this particular chronic constipation, there is going to be an increase in the pressure in the bowel. Because of this, what is going to happen? The mucosa is going to pop out. Okay, so mucosa is basically going to pop out from the potential defect. So we have this particular lumen. Okay, we have this particular lumen, and from these particular lumen where the arteries are basically entering into the bowel, okay, from here the mucosa basically can pop out. Okay, so this is what is called as a pulsion diverticulum. Pulsion diverticulum. This is also referred to as a false diverticulum. False diverticulum. So what is this? This is what is a pulsion diverticulum, or this is what is a false diverticulum, which you're basically having over here. Okay, so pulsion diverticulum or a false diverticulum. So chronic constipation, pulsion diverticulum, false diverticulum. This is what is referred to as a diverticulosis. Okay, so what is a diverticulosis? Diverticulosis is the presence of the diverticulum. Okay, so please try to understand there is a difference between diverticulosis and so what is a diverticulosis? That is the presence of the pulsion diverticulum. So this is what? This is the presence of the pulsion diverticulum. Pulsion diverticulum. This is what you call as a diverticulosis. Okay, so this is what is your diverticulosis. Okay, now if at all this particular diverticulum gets infected, okay, if at all this basically gets infected, then what we have is a diverticulitis. What is a diverticulitis? Diverticulitis is a condition where there is a infection inside this particular diverticulum. So like around the diverticulum there is inflammation and all those particular stuff. Okay, now the important thing which they keep on asking is that what is the investigation of choice? If at all they ask you the investigation of choice for the diverticulosis, what is going to be the answer? It is going to be the barium enema. Okay, so what is going to be the answer in the diverticulosis? In the diverticulosis, the answer is going to be the barium enema. So what kind of appearance do you get in the patients with the diverticulosis? What you basically get is this sawtooth appearance. So just look at this particular image, guys. This image is important. So this is what is a what is called as a sawtooth appearance. Okay, in the diverticulosis, what you basically have is this sawtooth appearance. Investigation of choice for the diverticulosis is the barium enema, and in this what you basically get is this sawtooth appearance. Okay, and what is an investigation of choice for the diverticulitis? Diverticulitis. So the investigation of choice for the diverticulitis is the CECT, contrast enhanced CT scan of the abdomen. Please try to understand this particular point, guys. Okay, investigation of choice for the diverticulosis is the barium enema, sawtooth appearance. Investigation of choice for the diverticulitis is the CECT. That is what you need to understand. Okay, understood? I hope you got this. Now right, Hinch's classification. So here what we have is a Hinch's classification. So what is this Hinch's classification? Hinch's classification is for the complications of the diverticulitis. Okay, so these Hinch's classification is for the complications of diverticulitis. What are these particular Hinch's classification? Hinch's type 1. What is this Hinch's type 1? This is what is called as a pericolic abscess. Okay, so there's a localized abscess. This is what is called as a pericolic abscess. Okay, pericolic abscess is your basically a localized abscess. This is what is your Hinch's type 1. What about the Hinch's type 2? Hinch's type 2 is basically your pelvic abscess. In the Hinch's type 2, what you basically get is a pelvic abscess. Okay, so what you basically get is a pelvic abscess. Pelvic abscess is what is a feature of your Hinch's type 2. Okay, then what about the Hinch's type 3? In the Hinch's type 3, what you basically get is a purulent peritonitis. Purulent peritonitis. And in the Hinch's type 4, what you basically get is a feculent peritonitis. What you basically get over here is a feculent peritonitis. Okay, so in the Hinch's type 4, what you basically get is a feculent peritonitis. And this was the question which was asked you, right? So yeah, that's what you need to understand over here. Okay, right. Okay, got it. Now, a patient underwent a surgery for an inguinal hernia 5 days before. Now the patient comes to the hospital with the complaints of the fever. Which of the following is most likely cause of this particular patient? So inguinal hernia surgery 5 days before. Now the patient is coming to with the fever. What is the most likely cause? So please to understand the most likely cause of this. So this is basically a question based on the post-op fever. So what is the cause of this? This is what is a wound infection, the surgical site infection. Okay. So now let's talk about the what you call as a post-op fever. Okay, so what are the features of this particular post-op fever? This basically, like, depending on when the particular post-operative, on which post-operative fever is occurring, based on that we can basically divide them into the 5 W's. Okay, so we have the 5 W's. This is basically defined by the 5 W's. What is this first W? This is basically the wind. What do you understand by the wind? Wind basically means that there is a lung infection. So there can be a lung infection. Okay, so in the post-operative period, the patients may have atelectasis, and the atelectasis can lead to the consolidation and the lung infection and the pneumonitis and everything. So that is what you need to understand. That is on the post. Okay, so this usually happens on the post-operative day 1 to 2, POD 1 to 2. Okay, what you basically get is this, the first W, that is a lung infection. Okay, then what we have, what is the second W? Second W is basically water. What does this particular water stands for? Here there is a urinary tract infection. Okay, so here what you have is a urinary tract infection, and what you need to understand over here that this is usually occurring on the post-operative day 2 to 4. Okay, so in the post-operative day 2 to 4, what you basically have is a urinary tract infection. So that is what you need to understand over here. Then what is the third W? Third W is basically walking. What is this particular walking? Walking is basically the DVT, which has led to the pulmonary embolism. Okay, and yeah, this usually occurs on the POD 5. Okay, 5. Okay, that's fine. Then what we have? We have basically wound. Wound basically means the wound infection. Wound infection, and this usually occurs on the POD 6 to 7. Okay, in the POD 6 to 7, what you basically have is the wound. Okay, then finally what we have is the fifth W is basically what you call as your drugs, the wonder drugs. Wonder drugs. So what are these? So yeah, the drug fever. So this is basically your drug fever, right? You understand my point? So these are the 5 W's which you basically have over here. Okay, post-op fever, wind, water, walking, wounds, and wonder drugs. Okay, I hope you are able to understand this particular stuff. Okay, got it? Okay, so yeah, these are the things which you need to understand. These are the causes of your post-op fever, the 5 W's, causes of your post-op fever. Okay, got it. Now let's move on to the next question. Pulmonary capillary wedge pressure increases in which of the following? So we just discussed the pulmonary capillary wedge pressure is going to increase in which of the following. Okay, we did not discuss this, but yeah, which of these, what is the answer? What do you think? What is the answer over here? The answer over here is, it is a cardiogenic shock. Okay, in the cardiogenic shock, what is going to happen? The pulmonary capillary wedge pressure is going to increase. Okay, so what is this particular pulmonary capillary wedge pressure? So what you need to understand is that we have the right side of the heart, then we have right atrium, right ventricle, then we have a left atrium, and then we have a left ventricle. What happens is that the blood basically comes from the periphery to the right atrium, it goes to the right ventricle, from here it basically goes to the lungs. Okay, it goes to the lungs, from the lungs it basically comes to the left atrium, from there it basically goes to the left ventricle, and from there it basically goes to the body. You understand my point? Now if at all, just imagine that if at all this particular heart fails, okay, if at all this particular heart fails, it means that the left ventricle is not able to kind of contract in a proper manner. So what is going to happen? There's going to be the stagnation of the blood over here. So this stagnated blood is going to kind of put a pressure over the kind of a left atrium, and over from here the pressure is going to be put on the lung. So there's going to be the back pressure which is going to be put on the lungs. Okay, so there's going to be the back pressure which is going to be put on the lungs, and yeah, the back pressure is also going to be put on the right ventricle as well. Are you understand my point? So pulmonary capillary wedge pressure is this. Okay, in the pulmonary capillaries, if at all the pressure increases, that is what is called as the pulmonary capillary wedge pressure. So this pulmonary capillary wedge pressure is something which is going to be high in the cardiogenic shock. Okay, in the hypovolemic shock, what is going to happen? Overall the blood in the body is going to go down, so there's no point of increasing in the pulmonary capillary wedge pressure. That is not going to kind of be there. In the septic shock, what is going to happen? In the septic shock, there's going to be the peripheral pooling of the blood. There's going to be the peripheral pooling of the blood. Okay, so the blood will be more in the peripheral circulation. There's not going to be the increase in the blood in the what you call as the central circulation. Are you understand my point? So again, there's not going to be any rise in the pulmonary capillary wedge pressure. Same is for the anaphylactic shock. In the anaphylactic shock also, the total peripheral resistance is basically going down, and that is why there is going to be the peripheral pooling of the blood. Okay, so I hope you have understood. There's no point of covering the entire shock over here at this point of time, but in the cardiogenic shock, because the heart is failing, there's going to be the increase in the pressure in these particular pulmonary capillaries, and that is why there is a pulmonary capillary wedge pressure which is increasing in the cardiogenic shock. Okay, now there is a 45-year-old kind of post-menopausal lady presenting with the following appearance on the breast. What is the T stage of the breast cancer? Okay, so just look at this particular image of the kind of the skin of the breast, and yeah, can you please tell me yeah, what is the stage of this T stage of this particular breast cancer? So the T stage of this particular breast cancer is what? Is it like the T4A, T4B, T4C, T4D? So answer over here is T4B. Okay, what is this? There is a skin involvement. What you're basically getting over here is no. Okay, so what you need to understand here, you have a Pau d'Orange, and that is why what you need to understand over here, what is the involvement of the skin, which is basically a T4B. Okay, so involvement of the skin, that is what is here, T4B. Okay, I hope you have understood. Now, the TNM staging of the breast is absolutely important, so I'll take some kind of time to revise it for you guys. So if you know it, just revise it with me. If you don't know it, just kind of remember this, because this is one of the very, very important MCQs for your upcoming kind of FMGE exams. Okay, so TNM staging of the breast, what you need to understand, first we are talking about the T stage. So what we have a T1, we have a T2, we have T3. What is T1? T1 is when the size of the tumor is less than 2 centimeters. What is a T2? The size of the tumor is between 2 centimeters to 5 centimeters. What is T3? Size of the tumor is more than 5 centimeters, but the tumor is limited to the breast. Okay, so less than 2 centimeters, 2 to 5 centimeters, more than 5 centimeters. Very, very important. Okay, then what we have T4, we have T4A. What is a T4A? So I'm pretty sure that many of the students, they get confused between the T4A and the T4B. The way I tell the students to kind of remember is that whenever you kind of screw up in your life, always try to blame yourself first, or try to kind of do the self introspection first. Okay, so what is a T4A? That is what is involvement of the chest wall inside. Just look inside first. So chest wall involvement. Okay, so in the chest wall involvement, what is included? Okay, so what is included in this particular chest wall involvement? If at all there is involvement of the ribs, if at all there is involvement of the intercostal muscle, if at all there is involvement of a serratus anterior muscle. Okay, so this is what is basically involvement of the chest wall. Okay, so ribs, intercostal muscles, serratus anterior muscle, this is what you need to understand is the involvement of the chest wall. Okay, what is not included? So pectoralis major and pectoralis minor, this is not included as involvement of the chest wall. Okay, pectoralis major and the pectoralis minor is not included as the involvement of the chest wall. Please remember this point, very, very important. Okay, what about the T4B? In the T4B, what do we have? We have involvement of the skin. Okay, so here what we have is we have the skin involvement. Okay, so what is included in this particular skin involvement? So we have Pau d'Orange. Okay, or let's say if at all you have a nodule or you have an ulceration. Okay, so nodule or an ulceration of the Pau d'Orange, these are the things which are included. So if at all the question says that, you know what, there is an ulceration, there is what is called as involvement of this particular like ulceration is there, nodule is there, or podiorange is there. All these particular things are said to be a part of involvement of the skin. Okay, but if at all, let's say they say that there is a nipple retraction, okay, or there is dimpling. Okay, if at all there is a dimpling or there is a nipple retraction, that is not included as a part of the kind of a skin. Please understand this particular point. Okay, nipple retraction and the dimpling is not a part of involvement of the skin. Why do these particular things occur? They basically involve they basically occur because of the involvement of the ligament of Cooper. So ligament of Cooper involvement leads to this nipple retraction and the dimpling and everything. But yeah, that's what you need to understand over here. What is a T4C? T4C is basically both, like the involvement of the skin plus the chest wall. If at all there is involvement of the skin plus the chest wall, that is a T4C. And what is a T4D? T4D is basically inflammatory breast cancer. So what is this? This is what is an inflammatory breast carcinoma. Okay, inflammatory breast carcinoma is basically T4D. Okay, I hope you have understood. This is what is the T stage of the patients. Okay, T stage of the breast cancer. Then what we have? We have what you call as the N stage. So what about the N stage? N1. What is N1? N1 is basically so like mobile axillary lymph node. Okay, so axillary lymph node, mobile axillary lymph node enlargement, that is what is the N1. What about the N2? N2 is divided into N2A and the N2B. What is N2A? N2A is basically fixed axillary lymph node. Okay, so fixed axillary lymph node is basically N2A. I hope you are able to understand this point. Okay, now what about the N2B? N2B is involvement of an internal mammary lymph node present, but there is no axillary lymph node. Okay, so there is no axillary lymph node involvement, but the internal mammary lymph node is kind of involved. What about the N3? N3 is divided into N3A, N3B, and the N3C. What is N3A? N3A is infraclavicular lymph node. What about the N3B? N3B is axillary plus internal mammary group of lymph nodes. What about the N3C? N3C is supraclavicular group of lymph nodes. Okay, are you understanding my point? So very, very important. The N stages are also very, very important. What is N1? Mobile axillary group of lymph nodes. N2 is divided into N2A and N2B. N2A is fixed. So if at all the question mentions matted, okay, matted and fixed are one and the same thing. So fixed and matted and fixed are one and the same thing. So matted or the fixed axillary lymph node, this is what is an N2A. N2B is internal mammary group of lymph nodes with no axillary lymph node involvement. N3 is divided into A, B, and C. A is basically infraclavicular, then axillary plus the internal mammary, and then the supraclavicular. Okay, so these are the things which you need to understand. Now, what is the name of the surgery which has been given below? Okay, so just look at this particular image, and yeah, surprisingly, this was one of the questions which was asked in the recent times in your FMGE exams. What is this, guys? What is this? So what you're basically seeing over here is a pancreaticojejunostomy. So what is this? This is what is your longitudinal pancreaticojejunostomy. This is also referred to as your Pustows procedure. Okay, so this is one of the surgeries which you basically do in the patients with chronic pancreatitis. Okay, in the chronic pancreatitis, what you basically do is this Pustows procedure or a longitudinal pancreaticojejunostomy. Okay, so I hope you have understood this point. This is one of the drainage procedures. Okay, so in the chronic pancreatitis, what we have is we have a drainage procedure and then we have a resection procedure. So this Pustows procedure is one of the drainage procedures which you basically do in the patients with a chronic pancreatitis. Okay, Pustows or a longitudinal kind of a pancreaticojejunostomy. So please try to remember this. I will not go into the details of this. Just remember, it's not a very, very high yield topic. So I'll just kind of move on to the more important topics. But I hope you have understood that what the image which you are showing over here, this is what is a longitudinal pancreaticojejunostomy. That is a Pustows procedure. Okay, understood? Now, coming to the Borman's classification. So the Borman's classification is basically used for which cancer? So this is basically used for the gastric cancer. Okay. So in the gastric cancer, we have multiple classifications. One is basically your Japanese Stewart classification. The Stewart classification, okay, again, not that important. This is a Japanese classification, which is basically for your early gastric cancers. So just at least remember the names. Okay, so what are the names? So first is the Stewart classification. Second one is the Japanese classification. The third one is the Borman's classification. So in the Borman's classification, what you need to understand that here you have type 1, type 2, type 3 and type 4. So what is the type 1 Borman classification? Type 1 Borman classification is that when you have a polypoidal lesion. Okay, so when you have a polypoidal lesion, that is a Borman's type 1. Type 2 is basically ulcerative. Type 3 is basically ulcero-infiltrative. And if at all it is a predominantly infiltrating kind of a tumor, that is what is a Borman's type 4. So you have to remember this. They might ask you linitis plastica. Okay, so linitis plastica is which type of a Borman's classification? Linitis plastica is a type 4 Borman's classification. Very, very important. What is this linitis plastica? This is what is a leather bottle stomach. Okay, this is what is called as a leather bottle stomach. So linitis plastica, leather bottle stomach, type 4 Borman's classification. Important kind of an MCQ. Now, one classification which you should know is Lawrence classification. What is this Lawrence classification for the gastric cancer? Okay, what is this particular Lawrence classification for the gastric cancer? What you need to understand over here, this is what is an histopathological kind of classification. Based on the histopathology, what you basically get is this Lawrence classification. So this Lawrence classification, they divide the gastric cancer into the intestinal and the diffuse variety. Okay, so intestinal and the diffuse variety. So what you need to understand is that if at all, so in the intestine, what are the characteristics of the intestinal type of the gastric cancer? They occur in the like the elderly population, so more than 50 to 60 years of age. So they basically occur over there. They are basically having an environmental risk factors like H. pylori. Okay, they are the ones which are more common in the males as compared to the females. Okay, and yeah, these are the things. On the other hand, the diffuse type, what you need to understand is that this is occurring in the young, and this is what is more common in the females as compared to that of the males, and this is what is having a genetic risk factor. So what do you get in this? What genetic mutation do you basically get? E-cadherin mutation. Okay, E-cadherin mutation is something which you basically get in the patients with the diffuse type of the gastric cancer. Very, very important. Okay, and lastly, what you need to understand, if they mention that there is a signet ring cells, please remember this is important. So signet ring cells are basically seen in the diffuse type of the gastric cancer. Okay, in the diffuse type of the gastric cancer, what you basically find is a signet ring cell. Very, 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 very important. Okay, right. Now, the diffuse type of the gastric cancers, they are more hematogenous metastasis. Hematogenous mets are basically present over here. In the intestinal type, they are the lymphatic mets. Okay, so what we have is over here lymphatic mets. Lymphatic mets are basically seen in your intestinal type. Hematogenous mets are basically seen in your what you call as a diffuse type. Very, very important. Okay, so these are very important. I hope you are able to understand this point. Okay, intestinal means metaplasia or metastasis to intestine. No. This is a histopathology. On the histopathology, if at all, so this is like the histopathology people, they kind of saw that particular this is an adenocarcinoma. So please try to understand Lawrence classification is basically for the gastric cancer. So when you did an upper GI endoscopy and you took a biopsy, based on whatever the histopathology on the slide, what the kind of the cells were being visible, based on that you divided into intestinal and the diffuse. It's just the name which is given intestinal. So probably it had more kind of a columnar cells or something like that. But like this has nothing to do with any metastasis to the intestine or like anything like that. It's not a metaplasia or anything like that. Okay, it's a cancer. Okay, it's a cancer. I hope you're able to understand this that way. Okay, got it? Okay, got it. Now a man opens his eyes to the pain, speaking inappropriate words, withdrawal to the pain. What is the Glasgow coma scale? So let's kind of calculate. Okay, so opening the eyes to the pain. Okay, so what is this? This is E2. Okay, what about the speaking inappropriate words? So what is this? What is B? Inappropriate, right? So this is what is your E3. Okay, E3. Okay, then what we have is withdrawal to the pain. So withdrawal to the pain is basically your M4. Okay, so this is what is your E2, V3, and M4. The answer is B. Okay, I hope you got this right. Okay, understood. Now this is again a very important stuff, so I'll not write it because I'm pretty sure that you would have kind of reread this so many times. I'll just quickly revise it for you guys. So what is this? We have a GCS, that is a Glasgow Coma scale. This is basically used to look for the mental status of the patient. Okay, so in this what we have an eye-opening response, we have a verbal response, we have a motor response. So what is an eye-opening response? Eye-opening response is that if at all the patient opens the eyes spontaneously. What is that? Okay, if at all the patient is opening the eyes spontaneously, what is this? This is what is an E4. Okay, E4 is opening the eyes spontaneously. What is E3? E3 is when the patient opens the eyes on the verbal command. Okay, when you go and talk to the patient and the patient opens the eyes, that is a E3. If at all there is an opening of the eyes to whatever the painful stimulus, that is what is a E2. And if at all the patient is not able to open the eyes at all, that is what is a E1. What is the verbal component? So for V5 is basically patient is well oriented to the time, place, and person patient is actually talking to and everything. What is the V4? V4 is that patient is confused. So patient takes some time to kind of arise to the final answer, but the patient ultimately kind of gives you the appropriate answer. That is what is your V4. Then what about the V3? V3 basically means inappropriate words. In other words, that you are asking patient something, patient is talking about something else, or maybe the patient is starting to abuse you. So whatever the patient is trying to tell or say, it does make some sense. It does have some meaning, but it is irrelevant to the conversation which you're having to that particular patient. That is what is your V3. What about the V2? V2 basically means incomprehensible sound. Okay, it means that patient is trying to say something. Okay, patient is trying to say something, but what you need to understand is that patient is trying to say something, but patient is whatever the patient is trying to say, it doesn't make any sense. So patient is just making sounds, something like that. Okay, what is V1? V1 means there is no verbal response at all. And then what about the motor response? In the motor response, what we have is we have M6. M6 says basically that patient is following the commands. You ask the patients to lift the hands, lift the legs, patient is able to follow the commands properly. What is the M5? M5 is basically the patient localizes the pain. So when you kind of pinch to the patient localizes the pain. That is what is M5. What is M4? M4 is basically that when the patient is there and when you kind of give the painful stimulus to the patient takes the hand away. That is what is an M4. What is M3? M3 is basically abnormal flexion, and then the M2 is basically abnormal extension, M1 is basically no movement at all. So this is what is a GCS, Glasgow Coma scale of the patients. Okay, now based on that you basically divide. If at all the GCS is basically less than or equal to 8, this is what is a severe head injury. If at all the GCS is basically between 9 to 12, this is what is a moderate. And if at all it is, let's say, 13 to 15, that is what is your severe. Okay, I hope you're able to understand. Mild or this is what is your mild. Okay, so between 13 to 15 is your mild. Okay, 13 to 15 is your mild head injury. Okay, so mild, moderate, and the severe head injury. This is what you need to understand. Okay. Okay, got it? Right. Right, so this is what you need to understand about this. Okay, so this is what you need to understand. Okay, now the patient presented with a history of a fever and pain in the right lower abdomen in the last 5 days. On kind of palpation, there's a painful lump which is palpable on the right iliac fossa. On examination, investigation, there's a leukocytosis found, which is the most probable diagnosis. And this is again very important for you guys. Okay, so the patient was coming to with a history of a fever and there is a pain in the right lower abdomen for the last 5 days. On palpation, there is a palpable lump which is palpable on the right iliac fossa. On the water investigation, leukocytosis, that the TLC count is basically elevated. What is the most probable diagnosis of this particular patient? Yeah, please tell me. Okay, so Vaibhav, thank you so much. But yeah, like in that 11 hours, obviously, the entire surgery cannot be kind of completed. I have just kind of covered the important topics in that. So probably I have discussed in that around 70, 80, 90 questions, I guess. I don't know. But yeah, those particular topics I have discussed in a bit more detail. Okay, got it? Okay, so what is the answer over here? Answer over here is appendicular lump. Very nice. Okay, so for your FMG, again, appendicitis and the appendicular lump and the appendicular abscess, these are very important. So what is this particular appendicular lump? So what happens is that sometimes when there is appendicitis and let's say there is a localized rupture or something, and the omentum basically comes and basically forms a kind of covering over that particular place, and it basically restricts the spread of the abscess from that particular place. This is what is referred to as an appendicular lump, and this is what is a characteristic description of the appendicular lump which you will get. So what is this particular description of the appendicular lump? As you can see over here, that there is a history of the fever and the pain in the right lower abdomen and all this particular stuff, and you're able to kind of palpate the proper lump is basically palpated in the right iliac fossa, and on the blood test what you have is that the TLC counts are elevated. Okay, so lump, in the question only they have given you that there is a kind of painful lump. So yeah, this is what is an appendicular lump. In the appendicitis they will not give you any appendicular lump, and in the appendicular abscess they will give you that the patients are very sick. So basically they are giving you that the TLC counts are very high, or the fever is very high grade, or they will give you that there is a skin changes in the right iliac fossa and all those things. That is what is an appendicular abscess. Now the important thing about the appendicular lump is what is the management. The management of the appendicular lump is Ochsner Sherin regime. Okay, so what you basically do in this particular Ochsner Sherin regimen is that you basically give the antibiotics to the patients, and then you do an interval appendectomy. So basically you kind of do the appendectomy after what you call as after some time. So let's say after 6 weeks to 8 weeks or something later, then basically you do this appendectomy. Okay, you understand my point? So Ochsner Sherin regimen, you give the antibiotics to the patients, and then you basically do the appendectomy after, let's say, 6 weeks to 8 weeks, 12 weeks or something like that. Okay, so later on you basically perform an appendectomy. Okay, that is what is an Ochsner Sherin regimen. Now, 32-year-old male presented with the severe vomiting and the back pain. They suggest that the childhood illness with the multiple skin thickening and the hyperpigmentation. Now he is taking everolimus. The CT scan shows a mass in the kidney. What is the diagnosis of this patient? So this is again, this is a question which is asked in your FMG, guys. This is important. But yeah, can you please tell me what is the diagnosis over here? Don't think that this is some weird question I have framed. This is a repeat question from your FMG exam. So can you please help me? What is the diagnosis over here? Okay, so guys, the diagnosis over here is an angiomyolipoma. Okay, so here what they have given you, that there is a severe vomiting and the back pain and everything, which suggests that there is a, okay, so that's fine, but they have given you that the multiple skin thickening is there, and there is a hyperpigmentation, and everolimus drug is being taken by the patient, and there's a mass in the kidney. Okay, so all these particular things, they basically point towards angiomyolipoma. So let's talk about the angiomyolipoma. Angiomyolipoma. Okay, so what is this? This is what is a tumor. This is a benign tumor of the kidney. Okay, so this is a benign tumor of the kidney which is consisting of the angio, that is a tumor of the blood vessels. Myo means involvement of the muscle layer, and lipoma means involvement of the fat. Okay, so there's involvement of the blood vessels, the muscles, and the fat, okay, in the kidney. This is a benign tumor of that. Now this is more common in the females as compared to the males, and this is the one which is associated with tuberous sclerosis. Tuberous sclerosis. Okay, so by this, okay, by telling you about this, hyperpigmentation and the thickening of the skin and everything, what they were trying to tell you that probably the patient is suffering from tuberous sclerosis. Okay, so that's the hint they were trying to give you over here. Okay, now here, okay, so there's going to be what you call as a mass in the kidney. That's fine. Okay, now what is an investigation of choice over here? The investigation of choice is a CT scan. Why? Because in the CT scan, you will be able to, like, if at all you have a -20 Hounsfield unit, which is basically corresponding to the fat. Okay, so what you want to distinguish this from? So angiomyolipoma, you need to kind of distinguish this from the renal cell carcinoma. Okay, so renal cell carcinoma is never ever going to have fat inside it. Okay, but if at all on the CT scan you find that there is a -20 Hounsfield unit density inside the kidney, then you are pretty much sure that you are dealing with what you call as your angiomyolipoma. Okay, so then you are pretty much sure that you are basically dealing with your angiomyolipoma. Okay, I hope you are able to understand these particular stuff. Okay, so this is about the angiomyolipoma. What about the management? So if at all the size of the kind of a tumor is less than 4 centimeters, then you just go ahead with an observation. But if at all the size of the tumor is more than 4 centimeters, then what you have to go ahead with a nephron sparing surgery. Okay, so then you have to go ahead with a nephron sparing surgery, that is a partial nephrectomy. Then you have to kind of go with a nephron sparing surgery or the partial nephrectomy. Okay, I hope you have understood this point. This is very important. Okay, now Forget about this, ET and everything. Okay, now this Tollman's procedure. This is again very, very important. Okay, so the Tollman's procedure is done for which condition? Can you please help me with this? Where do you perform this particular Tollman's procedure? Where do you perform this particular Tollman's procedure? Where do you perform this particular Tollman's procedure, guys? Yeah, the answer over here is a Zenker's diverticle. Right. So yes, guys, you are telling me about the other thing. So HMB 45 years, that is what is the tumor marker for that. Partial nephrectomy. Partial nephrectomy means that you preserve the kidney, right? So if at all, let's say there is a tumor. Okay, so let's say this is a kidney, and let's say there is a tumor over here. Okay, there's no point in removing the entire kidney, right? You can just kind of remove this part of the kidney, and you can just kind of get rid of this particular tumor. This is what is called as a partial nephrectomy or a nephron sparing surgery. Okay, so they had asked you what is an indication of doing a partial nephrectomy. In the benign tumor, obviously, for example, you have an angiomyolipoma or an oncocytoma, definitely you will prefer to go ahead with a nephron sparing surgery or the partial nephrectomy. But even if you have a renal cell carcinoma, and if at all the size of this particular renal cell carcinoma is less than 4 centimeters, then again you have to perform a what we call as a partial nephrectomy. Okay, then also you have to perform a partial nephrectomy. Okay, right? So guys, just give me like 2 minutes. I have kind of got an important call. I'll just get back to you. Just kind of take a break for 5 minutes. I'll be get back. Okay, but stay here only. Don't go anywhere. We have, let's say, around 10 to 12 questions more to cover. We'll wrap it up by, let's say, 11:30, 11:45. We'll wrap it up. But just give me like 5 minutes. I'll get back to you. Just stay here. Okay. No, sorry guys. I mean, that was an important phone from the family. I had to kind of take it. I'm really sorry for that. Yeah, coming back. Sorry to keep you guys waiting. And I can see many of you have left, but no issues. Let's kind of continue over here. So yes, the Dolman procedure is something which is basically done for the Zenker's diverticulum. So what is this? This is basically your staple diverticulopexy. Okay, so this is what is a staple diverticulopexy. Okay, so let's kind of revise the Zenker's diverticulum. What is this particular Zenker's diverticulum? Zenker's diverticulum. So Zenker's diverticulum is basically a false diverticulum. Okay, what is this? This is what is a false diverticulum, which you basically get in the upper esophagus. Okay, so this is what is your false diverticulum, which you basically get in the upper esophagus. So what happens is that there are two muscles group. There's a thyropharyngeus muscle and there is a cricopharyngeus muscle. Okay, and there is a potential kind of a triangle between them. This is what is called as a Killian's triangle. Okay, what is there? There is a Killian's triangle which you basically get between the thyropharyngeus and the cricopharyngeus muscle. Okay, right now what you need to understand is that if at all there is a neuromuscular incoordination, when the thyropharyngeus muscle is contracting and the cricopharyngeus muscle, it fails to relax, what is going to happen? Oh, because of this, what is going to happen? There's going to be increase in the pressure in the esophagus. Okay, and if at all there is an increase in the pressure inside this particular esophagus, what is going to happen? The mucosa will pop out from the Killian's triangle. From the Killian's triangle, the mucosa is going to basically pop out, and this is what is called as a Zenker's diverticulum. Okay, so what is this? This is what is referred to as your Zenker's diverticulum. So this starts posterior in the midline and everything. What about the clinical features? What will be the clinical features of this particular patient? So patients are going to have a dysphagia. Okay, and please understand that dysphagia will be non-progressive. Okay, non-progressive dysphagia. What else the patients are going to have? The patients are going to have halitosis. That is a bad odor. Why? Because here what is happening, that there is a part of the esophagus which is kind of coming like this. So whatever the foods the patients are going to have, that food might kind of get accumulated inside this particular diverticulum, and over a period of time it can become decayed, and there can be whatever the foul smelling which can come, and that is what is referred to as your called as your halitosis. Okay, so halitosis. Okay, I hope you are able to understand this particular point. At the same time, what can happen, this kind of this partially digested food can sometimes get aspirated into the lungs, and the patients may develop pneumonitis or the lung abscess. Okay, the patients may develop the pneumonitis or the lung abscess because of the aspiration of these particular food particles into the lungs. Okay, so patients may develop the pneumonia, pneumonitis, all those particular stuff. Okay, I'll come back to you, Priya. Just give me a minute. We'll come back to that. Okay, so this is what about the clinical features. What about the investigation of choice? Investigation of choice is your barium swallow. Okay, what is this? This is a barium swallow. And in the barium swallow, what are you going to find? You're going to find that there's a dye which is basically entering into the esophagus, as well as it is basically entering into this particular diverticulum. So barium swallow is broadly what you need to understand is the investigation of choice to diagnose these particular stuff. Okay, now when you talk about the management, so the management, if at all the size of the diverticulum is very small, so very small diverticulum, that is if at all the diverticulum size is less than 2 centimeters, then pharyngomyotomy will be sufficient. Okay, even if you kind of just cut the cricopharyngeus muscle slightly, and this is going to relax the cricopharyngeus muscle a bit, and that is what is going to be enough. But if at all, let's say the what you call as there is a the size is basically between 2 to 5 centimeters, then you basically perform this Dollmann's procedure. Okay, what is this? Dollmann's procedure. So here what you basically do is, this is what is a staple diverticulopexy. So you basically go in, and with the help of a stapler, what you basically do is you take down the wall between this particular diverticulum and the actual lumen of the esophagus. So once you kind of do that, what you need to understand is that earlier you had the esophagus like this, right? The diverticulum was like this. Now once you basically go in and you fire the stapler between these two particular walls and everything, ultimately what is going to happen, that is the lumen is going to be like this. Okay, so the wall is basically taken down, and now there is a common pathway and all. So this is what you need to understand. This is what is a staplered diverticulopexy. Okay, so this is what is a barium swallow. What is this? This is what is a barium swallow where you are basically getting this particular Zenker's diverticulum. Barium swallow where you're getting this particular Zenker's diverticulum. Okay, and if at all the size is basically more than 5 centimeters, then you have to perform a diverticulectomy. Diverticulectomy. Okay, then you have to kind of perform a diverticulectomy. You have to kind of remove that particular diverticulum, cut that, throw it off. That's what you have to do. Okay, I hope you're able to understand these particular things. Okay, understood? Right. Now, there's a male patient presenting to the OPD with an abdominal lump in the periumbilical region, which moves at right angle to the attachment of the mesentery. What is the most likely diagnosis? Again, a repeat question from your FMGE exam, guys. So can you please help me with this? So there's a periumbilical lump which is basically moving like at right angle to the attachment of the mesentery. Okay, so what we are dealing with, this is a mesenteric cyst. Now, out of all the options which are given over here, only the chylolymphatic cyst is the mesenteric cyst. Okay, so rest all other not the mesenteric cyst. So answer over here is a chylolymphatic. But before I proceed forward, Priya had asked me one particular question. So mid-esophageal diverticulum. Okay, so I just remembered. So mid-esophageal diverticulum. So yes, they are the true diverticulum. So why do they occur? So let's assume that this is the esophagus. What you need to understand, in the mediastinum there are multiple groups of lymph nodes. Now these particular lymph nodes, they may get inflamed. Okay, so once these particular what you call as mediastinal lymph nodes, they get inflamed, what can happen? They can get stuck, like they can attach to these particular kind of the esophagus, right? Now what are the diseases where these particular mediastinal lymph nodes are going to get inflamed? Tuberculosis, sarcoidosis, okay, all these particular places. So when they are getting bigger and large and inflamed and everything, they are basically coming in contact with the esophagus. And once you give these particular patients antibiotics, and once you treat these particular patients, what is going to happen because of this? There's going to be the lymph nodes are basically going to retract, and there's going to be the scarring. So there is going to be what you call as a scarring in the what you call as the lymph nodes and everything. So because of this particular scarring, what is going to happen? The esophagus will be pulled. Okay, so here in the mid-esophageal diverticulum, they are not the pulsion diverticulums, but what are they? They are the traction diverticulum. Okay, what are they? They are the traction diverticulum, which you need to understand over here. So these particular lymph nodes, when they kind of heal up, what is going to happen? They're going to pull the esophagus. Okay, so that is why they are the traction diverticulums. Okay, that is why they are the true diverticulum. All the layers of the esophagus are basically filled with them. Are you understanding my point? So I hope you have understood. So this is what is basically called as a traction diverticulum. Mid-esophageal diverticulums are the traction diverticulums. Yes, right. So over here, what you need to understand, I understood, Priya. I hope you got this. Okay. Now, what is this? This is a mesenteric cyst. Now, as you can understand, there are two types of the mesenteric cyst. One is the chylolymphatic cyst. What happens in the chylolymphatic cyst is that the lymphatics are basically accumulated inside the mesentery. Okay, so what happens in the chylolymphatic cyst? That is the lymphatics are the ones which are basically getting accumulated inside the mesentery. But the advantage of the chylolymphatic cyst is that the blood supply to these particular cysts is separate from the intestine. So here the management is enucleation. Enucleation. Why? Because the blood supply to these particular cysts is kind of separate. So the blood supply to the cyst is separate from the intestine, and that is why what you have to perform over here is an enucleation. Okay, I hope you're able to understand this point. But the other one is an enterogenous cyst. What are these enterogenous cysts? So these are the kind of intestinal duplication of the cysts. Okay, so these are the cysts which are attached to the intestine. So these are called as an enterogenous or an intestinal duplication cysts. Okay, now what you have to do in these particular cysts is that you have to go ahead with a resection and anastomosis. Resection and anastomosis. Okay, so what you need to understand is you have to cut this particular cyst over here, and then you have to attach the intestine with each other. So this is what is called as a resection and anastomosis. This is what you have to perform over here. Why? Because the blood supply is common between the intestine and this particular cyst. Okay, so blood supply is common, and that is why you have to basically what you have to do is you have to kind of do a resection and anastomosis over here. Okay, I hope you have to understand these particular points. Okay, right. And as you can see over here, this is the attachment of the mesentery over here. So this particular cyst, it moves perpendicular to the direction of that. Okay, so this particular cyst moves perpendicular to the direction of that. That is what you need to understand over here. Okay, understood? Now, there's a pregnant lady undergone a routine kind of an abdominal ultrasound. Following the finding has been noticed. What is the diagnosis of this particular patient? Now, one of the most important images for your exam, guys, for your FMG exam, one of the most important images. What is this? Obviously, I hope you're able to understand that what are you basically seeing over here. This is what is a posterior acoustic shadowing. What is this? This is a posterior acoustic shadow. Okay, what is this? This is what is a posterior acoustic shadow, and that is why the diagnosis over here is a gallstone. Okay, what is the diagnosis over here? The diagnosis over here is a gallstone, and what is you're dealing with? So this is what is a posterior acoustic shadowing inside the gallbladder. This is what is called as a gallstone. I hope you have understood this particular point, guys. Okay, now understood, this is a cholelithiasis. Okay, now I'll not cover everything related to it. Let's try to understand the indications of a prophylactic cholecystectomy. So if I ask you, what are the indications of prophylactic cholecystectomy? Okay, so what are the indications of a prophylactic cholecystectomy, guys? What you need to understand over here. So if at all you have a gallstone which is more than 2.5 centimeters, important, very, very important. Okay, gallstones more than 2.5 centimeters, or let's say there is a, okay, what is the diagnosis over here? What is this? What is this image? Okay, so please try to understand what is this? This is what is a porcelain gallbladder. Gallbladder. What do you understand by the porcelain gallbladder? This wall of the gallbladder, this is kind of calcified, right? So this is what is called as a porcelain gallbladder. You understand my point? So yeah, the porcelain gallbladder. Okay, so what are the indications? Porcelain gallbladder. If at all there is a gallbladder polyp with the stone. Okay, if at all there is a gallbladder polyp with the stone, or there is a porcelain gallbladder, there is a gallstone which is more than 2.5 centimeters, or there is a typhoid carrier. Just remember these. There are others as well. Hemolytic disorders, okay, bariatric surgery, transplant recipients. All these are the indications of a prophylactic cholecystectomy. But at least remember these four. Why these four are the indications of a prophylactic cholecystectomy? Because all these are the risk factor for the development of a gallbladder carcinoma. Okay, these are the risk factors for the development of a gallbladder carcinoma. That is what you need to understand over here. Okay, I hope you have understood, right? Important. Okay, what is this? These are the calcified gallstones. Okay, so if I ask you how many percentage of all the gallstones are calcified, the answer is only 10%, guys. Okay, so this has been asked once. How many percentage of all the gallstones are calcified? Only 10% of all the gallstones are calcified. Okay, so gallstones are usually not calcified, we do understand that, but only 10% of all the gallstones can be calcified. Okay, I hope you have understood this particular point, guys. Got it? Okay, now let's look at this. Okay, so there's an X-ray of a patient with an abdominal surgery shown below. Blah, 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 blah. The patient is a state of the ileus, which is the most common cause of paralytic ileus, prolonged paralytic ileus. So paralytic ileus is because of what? Okay, paralytic ileus is because of what? Paralytic ileus is because of hypokalemia. Okay, so what is a paralytic ileus? So paralytic ileus, what do you understand with the paralytic ileus? What do you understand with the ileus? Ileus, as I told you, that this is an intestinal obstruction, right? This is what is an intestinal obstruction. So what is in paralytic? Paralytic means there is an absence of the peristalsis. So this is an absence of peristalsis. Okay, absence of peristalsis, this is what is called as paralytic ileus. I hope you are able to understand this particular point, guys. Okay, understood? I hope you got this. Absence of peristalsis, paralytic ileus. So this can happen in the post-operative period. In the post-operative period, many patients develop this particular paralytic ileus. The regaining of the peristalsis is basically delayed in many particular individuals. Okay, so that is what you need to understand over here. So what you need to understand, Priya, is that the most common electrolyte abnormality which is associated with this is hypokalemia, and that is why you would remember that in the post-operative period you ask them to kind of eat the papaya and all those particular stuff, because we want bananas, we want them to kind of give the potassium. So are you understanding my point? The most common electrolyte abnormality is potassium. That's what you need to understand. Okay, understood? Got it? Now, so post-operative period, what happens that the intestinal peristalsis is basically yet to kind of regain, and that is why you basically have this particular paralytic ileus. That's what you need to understand over here. Okay, now here, what is going to be happening? The clinical features. Will there be colicky abdominal pain? No, there's going to be a dull aching pain. Okay, so please understand, in the intestinal kind of obstruction, what we have is an like a colic abdominal pain. But here we are not going to have a colic abdominal pain. Here we are going to have a dull aching pain. Okay. Okay. So here we are going to have a dull aching pain. Okay. I hope you have understood. Now, what else? Okay. Obviously, the peristalsis is going to be absent. So there's going to be an absence of peristalsis, and on the X-ray you are not going to have the multiple air fluid levels, but rather you're going to have a large dilated bowel loops. This is what you're going to have. So this is how you distinguish between the dynamic intestinal obstruction and an adynamic. Dynamic means that there is some kind of a physical obstruction. Adynamic means that is because of the reduction in the peristalsis. Okay, I hope you're able to understand. This is how you distinguish between the dynamic and an adynamic intestinal obstruction. Okay, I hope you have understood this particular point, guys. Okay, now important is about the management. How do you manage the patients of a paralytic ileus? Okay, so how do you manage the patients of a paralytic ileus? The management of the patients of a paralytic ileus is that you have to put a nasogastric tube, because once you put a nasogastric tube, what it does is it basically decompresses the abdomen. Okay, so it basically decompresses the abdomen. That is one thing. Along with this, what you have to give? You have to give electrolytes. Okay, so you have to give a fluid resuscitation, because the patients are in the state of a dehydration. So fluid resuscitation, that is what you have to kind of perform. And along with this, obviously, correction of the electrolytes. You understand the point? So this is what you have to kind of do over here. Okay, got it? Okay. Right. Now, a patient like post-surgery develops a low-grade fever on day 5, the pain in the calf and the pedal edema. What is the most probable diagnosis? So here, again, on the post-operative day 5 only, the patient post-surgery develops a low-grade fever on post-op day 5. There's a pain in the calf and the pedal edema. What is the most likely diagnosis over here? Okay, so the most likely diagnosis over here is what? Okay, got it. Right, so answer over here is DVT, deep venous thrombosis, guys. Okay, answer over here is a deep venous thrombosis. Okay, so I hope you have understood. Both presented with the post-op day 5 fever, but there it was a hernia surgery. In the hernia surgery, obviously there is no point of immobilization and everything, and there they did not give you this pain in the calf and everything. So because they have given you over pain in the calf and the pedilema and everything, that is why the diagnosis over here is a DVT. So this is again a point of your post-operative fever. Okay, so post-operative fever, that is what this particular thing is all about. Okay, got it. Now this is the last topic which we are going to discuss over here. Okay, so let's kind of cover this. This is an important one. A patient kind of sustains a road traffic accident and is taken to the emergency room, where he is found to have a pelvic fracture. So after the RTA, the patient is found to have a pelvic fracture. There is a blood at the tip of the meatus. What is the next step in the management of this particular patient? Okay, so this, I would say that this particular question is incomplete. I would add to this is that the patient is having the urge to pass urine is present, but patient is not able to pass urine, and on abdominal palpation the urinary bladder is palpable. Okay, now tell me, what is the next step in the management of this particular patient? Please help me. Yeah, can you please help me? What is the next step in the management of this particular patient? Right. So many of you have answered D. That is what is the correct answer. Good. It's good to kind of see that many of you have answered it correctly, but many of you still have answered it as C, and C is basically the most common wrong answer which you basically get, guys. Okay, so no, that is the most common wrong answer over here. Okay, so I'll come back to this and I'll explain it to you, don't worry. But yeah, so okay, so let's kind of first talk about this. Okay, so whenever you have a patient, okay, more topic is there. Okay, so what I'll do is, okay, so whenever you have a patient with a road traffic accident, and after that there is a patient who is having the urge present to pass urine, but the patient is not able to pass urine. Okay, and the bladder is palpable, the urinary bladder is palpable. Okay, in this particular scenario, what you suspect? You basically suspect a urethral injury. You suspect a urethral injury. Okay, you suspect, you're not confirmed whether the urethral injury is present or not. So what you need to understand is that in the next step, do not catheterize, catheterize. Do not put a Foley's catheter, no suprapubic catheter, no Foley's catheter, nothing. Somebody will say that, you know what, at some places they have written a single gentle attempt of the catheterization is still okay, but that's fine. But what you need to understand is that the risk is that you might end up converting a partial injury into a complete injury. So that is why it is not preferred. At least in your level, it is not preferred. So what the guidelines, what one particular guideline, EAU guideline basically says is that if there is a the single gentle attempt of the catheterization can be done with the senior most surgeon or the senior most person who is available in the emergency room. I understand my point, but the broad understanding as far as your MCQs are concerned, do not catheterize. So what is the next step? The next step is RGU, retrograde ureterogram. Because once you perform an RGU, so this is what is an RGU. Okay, now if I ask you that where is the stricture in these particular patients? Yes. So Priya, that's what I just explained to you, right? So as Priya is asking us, a single gentle abdominal catheterization can be done. Well, as I explained it to you, yeah, according to the EAU guidelines, yes, it can be done. But as far as your MCQs are concerned, if at all they have given you RGU and a Foley's catheterization, then you have to go ahead with the RGU. If they did not give you RGU in the option and the other option says exact these words, a single gentle attempt of the catheterization by the senior most person available in that particular trauma center, yes, you can kind of go ahead and mark that. Okay, but between this and the RGU, always prefer the RGU, at least on your level. Okay, now if I ask you that this is 0.1, this is 0.2, this is 0.3, this is 0.4, where is the urethral stricture present over here? Can you please help me? Where is the urethral stricture present? Where is the urethral stricture present? So please try to understand the urethral stricture is present at which place? Please tell me fast. Okay, so the urethral stricture is not present in these particular patients, guys. What is this? This is what is a normal RGU, guys. Okay, so many of you guys would have answered it as 0.3, right? Okay, yeah, 0.4. Okay, anyways, yeah, that's what you need to understand over here. No, this is what is a normal RGU, guys. Okay, what is this? This is a normal RGU. So what you need to understand is that this particular point where the urethra is basically kind of tapering like this is what is your the bulbar urethra is basically tapering into the membranous urethra. Okay, so here there is a urogenital diaphragm. This is what is a membranous urethra. This is what is your prostatic urethra. Okay, so this is what is a normal RGU. Why I'm showing you the image of this? Because it was shown to you a couple of years back. That shown you the image of a normal RGU. Do not get confused. This is not a stricture. This is a point where the bulbar urethra is basically entering into the membrane, like the urogenital diaphragm. Okay, I hope you're able to understand this particular point, guys. Okay, but yeah, if let's assume that there would have been some injury into the urethra or something, then yes, the dye would have kind of come out, and now you would have come to know whether there is any urethral injury present or not. So when you perform an RGU, if at all there is a urine or the dye leak, if at all the dye leaks from the urethra, then what you have to perform is an SPC. Okay, but if at all there is no dye leak, then what you can do is you can put a Foley's and you can just kind of keep that particular Foley's for some time, and then you can kind of remove it after 3 to 5 days. You can kind of remove it if at all there is no dye leak. You understand my point? But this is very important. After the road traffic accident, patient is not able to pass urine. Patient is having the urge to pass urine, but patient is not able to pass urine, and the bladder is palpable. Think of the bladder like urethral injury, and then what is the first step? Is a RGU, and if at all there is a dye leak, then you perform an SPC. Directly SPC is not to be done. Okay, I hope you are able to understand this particular stuff. Okay. No, if there is, and so what we basically use is a water soluble contrast, so it doesn't kind of harm that, doesn't harm to that significant level. Okay, so yeah, what we use is a water soluble contrast, low molecular weight water soluble contrast, so it doesn't kind of harm, and we obviously dilute it a lot in the saline before kind of putting it in. So yeah, it doesn't. Okay, got it? Okay. No wait and watch. Okay, so you have to kind of put a Foley's catheterization, because here the bladder neck would have kind of got and the spasm, or there would have been some edema in the bladder neck or something like that. So you have to kind of put a Foley's catheter for around 3 to 5 days, and then you can kind of remove it up. Okay, now let's talk about this. There's a patient with a history of a trauma and the ruptured bulbar urethra. What is the location of the accumulation of the fluid? So if at all there is a bulbar urethra rupture, where is the location where the urine is going to get accumulated? Is it like the superficial pouch, deep pouch, recto-uterine pouch, or the uretrovesical pouch? We'll get back to that, Priya. We are talking about the management of the urethral stricture now, so we'll get back to that. the next part of the urethral injury is still remaining. So we'll talk about that. Just give me a minute, okay? Right. So yeah, what do you think? What is the answer over here? The answer over here is the superficial pouch. Okay, so in the superficial perineal pouch. So here the urine is basically accumulating in the superficial perineal pouch. Okay, I hope you are able to understand this particular point, right? So now let's talk about this. Okay, so now let's talk about this. Okay, so what we need to understand is we need to understand about the anterior and the posterior urethral injury. Okay, so what we need to understand about the anterior and the posterior urethral injury. Anterior urethral injury and the posterior urethral injury. So what you need to understand, what is an anterior urethra, what is the posterior urethra? Anterior urethra is basically your penile urethra, the bulbar urethra. That is what is constituting the anterior urethra. What about the posterior urethra? The membranous urethra and the prostatic urethra. That is what is constituting the posterior urethra. Are you understanding my point? So in the anterior urethral injury, what is the mechanism of injury? So here there has to be a straddle injury. What do you understand by the straddle injury? So this is what is a manhole injury, and let's say the injury over the, so this, like for example, let's say the patient is driving a bicycle or anything and the patient basically kind of falls down. What happens is that this pure urethra is basically compressed between this particular bar and this particular pubic symphysis. So urethra is basically compressed between these two very, very hard structures, which might lead to the injury to the urethra. This is what is referred to as a straddle injury. What is this? This is what is a manhole injury. Walking, and basically this particular manhole comes and hits the patients in the crotch, which can lead to the urethral injury over here. So this is what is referred to as a straddle injury. Are you understanding my point? So anterior urethral injuries are associated with the straddle injuries. Now here, whenever there is an like anterior urethral injury, what you need to understand is, okay, so what we have a urogenital diaphragm, and okay, so what we have is we have a urogenital diaphragm, and whatever the area which is above the urogenital diaphragm, so what we have is this urinary bladder, prostatic urethra, then we have a membranous urethra, then we have a bulbar urethra, we have a penile urethra. So this is what is your urogenital diaphragm. This is what is your urogenital diaphragm. So if at all there is any injury which is below this particular urogenital diaphragm, this is what is going to, like bulbar urethra, penile urethra, what we are going to have is we are going to have a like there's going to be the urine accumulation in the superficial perineal pouch. Okay, so there's going to be the urine accumulation in the superficial perineal pouch. But if at all there is an injury into the prostatic urethra or the membranous urethra or something, there's going to be the urine accumulation in the deep perineal space or the deep perineal pouch. You understand my point? So very, very important this. Okay, so this is how it kind of looks like. Okay, so this is what is a urine accumulated in the superficial perineal space or the superficial perineal pouch. Okay, now so in the anterior urethral injury, what you basically get, there's a urine accumulation in the superficial perineal space. Okay, and what happens to the prostate over here? So prostate is high riding. So what you need to understand is that when you perform a digital rectal examination, either you're not able to palpate the prostate or the prostate is basically high up. So that is what is called as the high riding prostate. Okay, so when you basically do a digital rectal examination, prostate is not palpable or the prostate is high riding. That is what is again the feature of your anterior urethral injury. This is what is called as a Vermeulen sign. Vermeulen sign. Okay, so this is again what is the feature of your Vermeulen sign. Now you understand my point? And yeah, the anterior urethral injuries are the ones which are associated with the pelvic fracture. They are associated with the oh, I'm really sorry for this. I'm really sorry for the, oh, what the hell I'm doing. I'm really sorry for this. So my bad. So straddle injury is fine, superficial perineal space is fine, but this prostate high riding stuff, okay, this is where I screwed up. So by mistake I have kind of written over here, this is a part of your posterior urethral injury. We'll talk about that. Okay, so so this pelvic fracture and these are the parts of your posterior urethral injury. I'll talk to you about this. I kind of miswrote it over there, but please understand this. I'll repeat it. Anterior urethral injury, what you need to understand, straddle injury is there. There's a urine accumulation in the superficial perineal space. So this is also referred to as your butterfly shaped hematoma. Okay, what is it called as a butterfly shaped hematoma? Okay, so I'll show you the image of this. Just give me a minute. So how it basically looks like. Okay, so just look at this. Okay, so here there's a superficial perineal hematoma which is basically covering the scrotum and this particular anal region. So this is what is called as a, this looks like a butterfly, right? So this is what is a butterfly shaped hematoma, which you basically understand. And this particular urine can track down till the clavicle over here, because it basically goes through the superficial fascia and it can kind of go till over here, but it doesn't goes beyond this particular point because it is kind of guarded by this Holden's line. It doesn't go beyond the Holden's line. That is what you need to understand over here. So this is the urine accumulation in the anterior urethral injury. What about the posterior urethral injury? The mechanism of injury in the posterior urethral injury is a pelvic fracture, and here there's going to be the deep perineal hematoma. Okay, so there's going to be a deep perineal hematoma, and over here when you basically kind of do a digital rectal examination, the prostate is high riding or the prostate is not palpable. This is what is called as a Vermeulen sign. Okay, so this is what is called as a Vermeulen sign. Okay, right? Okay, understood. Now so let's kind of talk about the management. So how do you manage these particular patients? So whether the patient is having an anterior or the posterior urethral injury, so whenever there is a patient who is having a urethral injury, it doesn't matter whether it is anterior or the posterior or whatever, what you basically do is you put in suprapubic catheter and you send the patient home for around 2 to 3 months. Okay, then what you do, you call the patients back and they repeat the RGU. Okay, now what is going to happen in this 2 to 3 months? Whatever the injury is there, either it will kind of repair or heal on itself, or there is going to be the formation of a stricture. So like when you perform an RGU, if at all there is a presence of a stricture, then you have to perform a urethroplasty. Did you get your answer, Priya? I hope you understood this point. So yes, I mean, you have to repeat an RGU, and based on that, you have to decide whether you have to perform a urethroplasty or not. And Priya, you have written Buck's fascia intact, butterfly hematoma, eggplant deformity. So first of all, that's wrong. So this Buck's fascia intact and the eggplant deformity, this is what you basically get in the patients with a penile fracture. That's a different story. Urethral injury and the penile fracture are not the same thing. Okay, so if at all the Buck's fascia is intact in the penile fracture, then you are going to have the eggplant deformity. The butterfly hematoma is basically the superficial perineal hematoma, which you basically get in the anterior urethral injury. Okay, I hope you have understood this particular point, guys. Okay, understood? Penile fracture, Buck's fascia intact, eggplant deformity. Okay, but if at all there is an anterior urethral injury, what you basically get is a butterfly shaped hematoma. Okay, right? Now the last kind of question which I have over here is, there's a 50-year-old female patient presenting with a sudden onset headache. She described that this is the worst headache of the life, and the CT scan has been kind of given below. What is the diagnosis? Now this is not that easy an image to kind of diagnose, but yeah, let's kind of understand what you think. What is the answer over here? Okay. Okay, so yeah, what do you need to understand? What is the answer over here? The answer over here is subarachnoid hemorrhage. Okay, what is the answer over here? Subarachnoid hemorrhage. Understood? Got it? Yes? Okay, now let me just kind of get back to the death by. So I think you are getting confused with this particular protocol which I have written. So this is a diagnosed urethral injury, but in order to diagnose the patients with the urethral injury, you have to perform an SPC. So after performing you have to perform an RGU. So after performing an RGU, so first is that the patient is going to come, the patient is going to have a suspicion of a urethral injury. Now you did an RGU. In RGU, you were able to diagnose the urethral injury. And once you have diagnosed the patients on the urethral injury, now you put an SPC. So there's no difference. I understand my point. This is a continuation of the management. Why I wrote this? Because Priya had asked me a doubt, right? So urethroplasty, when do you kind of do it, and delayed urethroplasty and all those particular stuff. That's why I kind of explained this to you. Okay, I hope you have understood, right? Got it? Okay, yeah. The answer over here is a subarachnoid hemorrhage. Okay, so what is the answer over here? This is what is a subarachnoid hemorrhage. Okay, now what is this? Pretty simple. Now this is one of the images which you cannot do wrong. If you are kind of appearing for the FMGE exam, you cannot afford to get it wrong. What is this? This is an EDH, extradural hematoma. Okay, this extradural hematoma is occurring because of the injury to the middle meningeal artery. Okay, meningeal artery, which is basically present just below the pterion. That is what is the thinnest part of the skull. So injury to the middle meningeal artery leading to a biconvex opacity. That is what is an extradural hematoma. Okay, now what is this? This is what is a okay. So what is this? This is a biconvex opacity, or a lens-shaped opacity. That is what is an EDH. What is this? This is what is a concavo-convex opacity. What is this? This is a concavo-convex opacity. This is what is basically happening in the SDH, subdural hematoma. In the subdural hematoma, concavo-convex opacity. That is what you need to understand over here. Okay, this is happening because of the injury to the bridging veins. Okay, injury to the bridging veins. Okay, so I hope you have understood this particular point, guys. Yeah, so this is happening because of the injury to the bridging veins, concave or convex opacity. Over here what you have is a venous bleeding, and in the EDH what you have is a arterial bleeding because of the injury to the middle meningeal artery. Okay, so I hope you have understood this particular point, guys. Yep. Now this is all what I wish to cover with you guys. I understand this is not the complete surgery. I cannot cover the complete surgery over here, but I hope you have understood few things, and yep, I hope you kind of got some valuable information or the revision from this particular stuff, right? Okay, now before I kind of end this particular session, I will just share a couple of things with you guys. So you have your FMG exam day after tomorrow, and what you need to understand is that you have to pass, right? You have to kind of clear that particular mark of 150, right? So keep you cool, and every question carries the same mark. Okay, so you can what you call as okay, just wait a minute. Okay, right. So I'll get back to you. So then just give me 2 minutes. I'll get back to you. Just give me 2 minutes. Okay, right. Now what you need to understand is that every question is going to carry the same mark. So just kind of put your focus on doing the maximum questions correct. But if at all, let's say you get some particular question or something like that, just leave it, just move to the next one, because every question carries the same kind of marks. So just give your focus to all the questions equally. Okay, so don't kind of distribute your focus. For example, the subjects which you have not read, or let's say some questions which are very, very difficult, don't kind of put a lot of focus over those particular questions. Just give equal kind of focus on all the questions, and that is what is going to help you, because the time will be limited, and obviously you're going to commit the silly mistakes. There's no point about it. There's no doubt about it. The only thing is that you have to minimize these particular silly mistakes. Okay, so the two ways of minimizing the silly mistakes is, one is by the proper revisions and everything, and time for that has probably got over now. But the other way you can kind of minimize the silly mistakes is by being present on the day of the exam. So if you're present on the present means obviously you're going to be present. Present means by mentally present. Present means by with all your alertness and the consciousness when you're reading those particular questions. You have to be there. You have to kind of read those particular questions very, very carefully. You have to understand what they're trying to ask, and you have to kind of give the perfect, like the most probable answer which you can give in that particular place, or something like that. Some amount of anxiety is absolutely kind of okay, but I'm pretty sure that you would be seeing so many students around you who are absolutely kind of having no kind of pressure over them. Okay, so this basically, like, more often than not, these particular students are the ones who have not well prepared. So they're like, theek hai, jo hoga dekhenge, something like that. Okay, but if at all you are slightly anxious, that is good. That means that you have prepared a bit, you have put in your efforts a bit. Are you understanding my point? So if at all you have put in efforts a bit, that's good. And if some amount of anxiety is fine, but prolonged anxiety or a very, very massive amount of anxiety will be counterproductive. So don't be like too much anxious, but yeah, slight amount of anxiety is kind of productive. So yeah, you can go ahead with that. That's not an issue at all. And yeah, just that's it. Obviously we all hope and we all are trying that, you should kind of pass. You are basically trying that you should pass this particular exam, but at the end of the day, it's not the end of the world, right? So I'm pretty sure that you're going to clear it, but even if you don't, it's okay. It's not the end of the world. You will do whatever you have to do in this particular world. You will kind of do good. That's not an issue at all. But whatever you have read, whatever you have done for the last 6 months or 1 year or something like that, you have to ensure that you communicate that to the examiner. And the only way to communicate that to the examinees is that by marking the correct options and by reading the questions carefully, by answering what they're basically trying to ask. So don't screw up over there. Don't do the silly mistakes. Don't take the questions for granted. Even the silly, like even the simpler questions, give your full attention towards them and just mark those particular questions in a proper manner. So these are the things which you have to kind of consider. Just believe in yourself, and yeah, that's all it. Okay, if you have any particular doubts or anything, you can just put it in the comment box. I'll try to answer it. So Sudan is basically asking, so TURP, retrograde ejaculation, is due to the damage to the external sphincter or the internal sphincter. So what you need to understand is, you only will tell me. Okay, so what you need to understand, this is a urinary bladder, this is what is your prostatic urethra, then what we have is a membranous urethra, then we have a bulbar urethra, then we have a penile urethra. Okay, and then what we have over here, we have, this is what is your urogenital diaphragm. What is this? This is a urogenital diaphragm. And what you need to understand is, there are two sphincters in our body. In the males, there are two sphincters. One is an internal urethral sphincter, another one is your external urethral sphincter. Okay, now what happens is that there is a verumontanum. What is this? This is a verumontanum. So what is this particular verumontanum? Verumontanum is the place where the ejaculatory duct is basically coming from this particular smile vesicles and everything. The vas deferens comes, it basically joins, and it basically enters into this kind of verumontanum. Now what you need to understand is the erection is basically your parasympathetic process and the ejaculation is a sympathetic process. Now this in internal urethral sphincters, what you need to understand, you have an alpha 1 receptors. Okay, you have alpha 1 receptors. So whenever there is a sympathetic overactivity, what is going to happen? This internal sphincter is going to get closed. So when the internal sphincter is basically going to get closed, when the ejaculation happens, the ejaculate tries to go into the urinary bladder, but it is not able to go. So what happens is that it basically comes out. So this is what is happening normally, like in the males, this is normally happening because ejaculation is basically a sympathetic kind of a process. So the bladder neck is basically closing, and that is why the ejaculate is basically coming out. In the TURP, what do you do in the TURP? In the TURP, so this is a prostate over here, right? So there's a prostate also. Here in the TURP, what you do, you cut the prostate, and in the bargain, you end up destroying the internal urethral sphincter. And now, whenever there is a ejaculation, the ejaculate basically goes back. So answering your question, the thing is that so this basically happens because of the destruction of an internal urethral sphincter. But I hope you have understood this particular point. Got it, right? So you are able to kind of tell the answer over here. Okay, right? Okay, so what you need to understand over here, so please take down my number if you guys want. I'll just write down my number, so you can just kind of message me if at all you want the PDF of this particular class or anything, or any doubts, and I will also add you to a couple of groups if I have. I'm just trying to establish those particular things. They're not very active at this point of time, but I plan to kind of activate them very, very soon. So I'll do that, but you can just note down my number. So who am I? I am Dr. Pawan. I have been teaching on and off. The point is that I've also wanted to continue with my clinical career. So I've completed my urology very recently, and that's why I've again started teaching over here. But yeah, that's fine. But my number is, I'm Dr. Pawan, and my phone number is 98. Okay, so it is 9821254008. Okay, so this is what is my phone number. Okay, I hope you have understood. Now if at all you have some kind of, if you want this particular PDF or something like that, so yeah, you can just kind of message me and I'll share the PDF with you guys. Okay, so secondary contracture and the graph take up. Okay, so what you need to understand, there's something which is called as a primary contraction, there's something which is called as a secondary contraction. So what you need to understand is that, let's say if at all I have to take up a graft from here. Okay, so once I take up the graft from here, what is going to happen? The size of the graft is going to reduce a bit. Okay, why it is going to reduce a bit? Because this is because of the elastic recoil. So all you need to understand is that if at all you have a full thickness graft, it has more dermis, so it has a more elastic recoil, and that is why the primary contraction is more with the full thickness graft. Understood? Now once you have taken up, once you have taken up this particular graft, you put it at the recipient side. Once you put it at the recipient side, the process of the healing takes place, and the final process of the healing is that there is a wound contraction. In the phase of the remodeling, there is a wound contraction. So this is what is referred to as a secondary contraction. So I hope you have understood, Priya, that the primary contraction is more with the full thickness graft, and the secondary contraction is more with the partial thickness graft. Okay, I hope you are able to understand this, right? I hope you are able to understand this. Okay, so yes, this is my WhatsApp number. Okay, so what I've just kind of shared, this is what is my WhatsApp number. Okay, right. And graft take up. So, okay, so graft take up is basically, so there are three phases of the graft take up. First is the phase of the imbibition, then there is a phase of inosculation, and then there is a phase of revascularization. In the imbibition, what happens? Once you put up the graft on the recipient side, the graft basically receives the nutrients by the process of diffusion. That is what is called as a phase of the imbibition. Then you have an inosculation where the blood vessels are aligned with each other. And in the phase of revascularization, the proper blood vessel establishment is there. Okay, so the imbibition phase basically lasts for 24 to 48 hours. Then inosculation phase is basically from 2 to 5 days, and then after 5 to 7 days, there is a phase of the revascularization. Okay, I hope you are able to understand these particular things. Okay. So that's it, guys, and I will be keeping on taking these particular sessions. I have to again start on my own YouTube channel as well. If you want to kind of join, it's not like hardly anything is there at this point of time, but Surgery Unplugged by Dr. Pawan is the YouTube channel which I'm going to grow over the period of time. So you can kind of consider joining it. But obviously at this point of time, not very value-added content is over there. Probably in a couple of months, yeah, for the NEET PG, yeah, I'm planning kind of few sessions over there. You can consider joining it if at all you wish. Okay, so thank you so much, guys, and all the best for your particular exam, for your FMG exam. Hopefully the NEET PG dates are also going to come out soon, and you guys will be having some clarity over thoughts. And for the FMG, all the best. I hope your exam happens timely and you guys clear with good marks. Okay, thank you so much for patient listening, guys. So hope to see you soon. I'll be taking the recall session also for the surgery on the day of your exam. So yeah, let's kind of see you there again. Bye bye, take care, good night, see ya.